Hello. This lecture will review gastrointestinal and aerodigestive studies in pediatric nuclear medicine. Specifically, we will look at GI function and dysfunction as assessed with a gastric emptying study, which also can assess for gastroesophageal reflux. We will look at bronchopulmonary aspiration, esophageal transit, and GI bleeding using a Meckel scan. Now, when performing gastric emptying studies in children, selection of phase is important. Typically, we would try to use a solid gastric emptying study, as we would do in adults, but in many children, a liquid gastric emptying study or milk scan is more appropriate, particularly in infants who do not yet take solid food or in patients who do not take food by oral intake. Now, performing a gastric emptying study in children comes with certain challenges. Many are referred for evaluation of food intolerance or food allergies, and therefore may not be able to use the standard meal. Food preferences can be strong in children, and this may affect their ability to cooperate with the standard meal. And finally, the standard meal may be too large for many young children to complete. Until recently, there were no normative values for gastric emptying in children, and this limited our ability to perform a GI or a gastric emptying study accurately among different institutions. Because of this, a number of alternative meals have been suggested for use in pediatric gastric emptying studies. These included melted cheese, oatmeal, mashed potato, and a variety of other meals. And this compares to the standard gastric emptying meal, which includes egg whites, toasted white bread, jelly, and water. Now, if we are going to use an alternative, it should meet two requirements. First, there should be satisfactory binding of tracer. We typically use technetium-99m labeled sulfur colloid, as this binds well to the proteins in the egg or egg white. Secondly, the gastric handling characteristics should model typical gastric emptying. After all, that is the purpose of doing the study, and hopefully also will replicate emptying of the standard meal. About a decade ago, Drew Back and colleagues at Boston Children's Hospital looked at a number of potential alternatives to the standard meal and assessed whether sulfur colloid binding was complete in these different meals. They looked at egg white, cheese, and a number of alternatives, including oatmeal, mashed potatoes, and peanut butter. What they saw was that there was excellent binding of sulfur colloid to egg white and also to cheese, but there was variable binding of sulfur colloid tracer to oatmeal, mashed potato, and peanut butter. Therefore, it's appropriate to use the egg white for standard meal if we're able, but that cheese may be an appropriate alternative, and this could be provided in a variety of meals, including a cheese sandwich, macaroni and cheese, or even placed on a slice of pizza if that's what the patient would take. More recently, a multi-institutional group performed a retrospective study looking at over 1,100 gastric emptying studies that had been performed in children. These included studies performed across a range of ages, including both sexes, and retrospective analysis assessed that over 500 were normal subjects. This group then looked at the standard meal, a cheese alternative meal, and also looked at patients who had the standard meal that they were unable to complete, and divided these patients into two groups: those who ate more than half the standard meal and those who were not even able to eat half the standard meal. First, they looked at the adult normal, which is less than 10% residual by 4 hours, and were able to show that all of these alternatives met that criteria. So patients who had normal gastric emptying had less than 10% residual of any of these meals. And then secondly, they looked at the pattern of uptake, or pattern of emptying rather, and we can see all of these meals have a similar pattern of gastric emptying over time, telling us that either cheese or a partially consumed standard meal is an appropriate alternative to the standard meal. Now, the other way to perform a gastric emptying study is to use a liquid meal or a milk study. Typically, we will perform labeling with sulfur colloid of either milk or formula, which then can be administered by mouth or by tube, either nasogastric or G-tube. The volume of the meal is typically similar to that for the usual meal in a child, or if a patient is referred for evaluation of specific symptoms, we'll use the volume of formula that typically causes those symptoms. We perform dynamic imaging for 1 hour, then perform region of interest analysis to assess gastric emptying. This test is particularly sensitive for gastroesophageal reflux. And some studies have suggested that it may even be more sensitive than the solid meal for assessing impaired gastric emptying. When evaluating a liquid or milk study, it's important to recognize that the normal pattern of gastric emptying of a liquid is rapid with no lag time. It has a mono-exponential or decay curve pattern, as seen in this time activity curve. It's important to recognize that there will be emptying even during feeding, and this needs to be included in evaluation of gastric emptying. Gastric emptying has been evaluated either at 1 hour or 3 hours with a liquid meal. Typically, we have used a standard of more than 50% by 1 hour, although Quattro and others also showed that greater than 80% by 3 hours correlated with a normal study. Because these values are sort of similar in performance, it of course is much easier to perform the 1 hour study. It's important to look at the images to assess for gastroesophageal reflux, and it's important to maintain a consistent protocol so that patients can be referred from or can be compared from one study to the next, and that referring physicians understand the significance of a particular result. Some parameters that may affect gastric emptying, particularly with a liquid study, include the choice of meal. We typically use milk, breast milk, or formula rather than juice or water, which will not actually bind the sulfur colloid. The route of administration, oral versus tube, can have an effect on gastric emptying. And of course, the volume of administration, which is why we try to replicate the typical meal intake unless we're specifically using a volume that produces symptoms. Patient age and emotional upset can both have an effect on gastric emptying. And then finally, one other issue is the possibility that severe gastroesophageal reflux, that is retrograde emptying of the stomach, may affect the rate of anterograde emptying. And this needs to be evaluated on a case-by-case basis. Here's an example of a 19-month-old girl with feeding aversion and malnutrition. This is a liquid gastric emptying study. By looking at the images, we can see that there is rapid and near complete emptying of the stomach, and the gastric activity time activity curve confirms this, showing the typical mono-exponential or decay pattern curve with very little residual by the end of the study. Secondly, we can see here, as demonstrated with the red arrows, that there are 2 episodes of gastroesophageal reflux, which are confirmed on the esophageal time activity curve. Here's another case, a 17-month-old girl who's being fed by G-tube, and the family reports that she has severe gastroesophageal reflux symptoms. Now, as we look at this image, we can see that, again, there is rapid and near complete emptying of the stomach. But the difference is that when we look at the time activity curve, it's linear and not mono-exponential, suggesting that there is some impairment of gastric emptying. On the other hand, during the hour of imaging, we did not see any gastroesophageal reflux. Here's another case, a 9-year-old boy with a mitochondrial disorder and increasing intolerance of gastrostomy.tube feedings. Both inspection of the images and the gastric activity time activity curve show that there is minimal gastric emptying, making this a markedly abnormal study. And again, we see no gastroesophageal reflux. So the liquid gastric emptying study, or milk study, allows us to assess gastric emptying over 1 hour, and we can look at both a quantitative measure of gastric emptying as well as the pattern of emptying. and also allows us to assess for gastroesophageal reflux, looking at frequency, volume, and extent of reflux. Common indications for this study include patients in whom there is clinical concern for reflux, patients who have demonstrated regurgitation or vomiting, increasing feeding intolerance, post-feeding respiratory distress and concern for aspiration, although sometimes caution is appropriate as we don't want to have an episode of aspiration in the nuclear medicine department. And then patients who are going to have fundoplication surgery for reflux frequently undergo a milk study to confirm that there's normal anterograde emptying of the stomach. Other considerations, patients should be fasted before this study. We typically tell families to fast the patients for 4 hours. Although, if you have a patient who has markedly delayed gastric emptying and that the clinical suspicion is quite high, it may be appropriate to have them fast for a longer period of time, as we know there's going to be a prolonged delay in clearance of the prior meal from the stomach. Infants typically cannot fast for this long, and we ask them to fast only for 2 hours. This usually is appropriate because, in fact, they're taking only liquid meal, and that is going to clear faster. Patients are frequently on medications that may affect gastric motility or acid secretion, and whether the study is performed with or without these medications depends upon the clinical question. For example, if the clinician would like to know whether a pro-motility agent has improved gastric emptying, it would be appropriate to perform the study while the patient remains on the medication. However, if this is a baseline study, the clinician may want us to perform the study without medication, and therefore it's important to consult the referring clinician. Recently, there's been concern about applying food standards to preparation of the standard or alternative meal. And although we want to be safe, it's also appropriate to remember that this is a diagnostic test and not a meal. It's also appropriate that applying food standards not affect our ability to perform radiation safety. We do our best to limit emotional upset, as this can delay gastric emptying. And in some patients, it may be appropriate to consider prior assessment for aspiration even before performing the gastric emptying study. Here's a 3-month-old girl with poor feeding tolerance and recurrent respiratory distress. As we look at these images, we can see that there's delayed gastric emptying, and this is confirmed on the time activity curve. But in addition, we're seeing multiple episodes of gastroesophageal reflux, as demonstrated by the red arrows. This is frequent and of large volume, reaching high in the esophagus. Therefore, it may be appropriate to evaluate this patient for aspiration. Now, to evaluate for tracheobronchial aspiration, we perform a radionuclide salivagram. This is actually quite a simple test to perform. We take a drop of saline, which contains 0.1 millicurie of tech-labeled sulfur colloid. This is placed in the mouth, either under the tongue or on the back of the tongue. And then we perform dynamic imaging for 1 hour and look for accumulation of tracer in the airways. And it's also important to assess for spontaneous clearance, as it does provide some prognostic information. Here we can see tracer in the mouth as the patient turns their head back side to side, passage into the stomach, and unfortunately in this patient, accumulation of tracer within the airways. Here's a 3-year-old girl with a mitochondrial disorder and frequent pneumonia. After being administered tracer in the mouth, we can see rapid transit of tracer into the trachea and bronchi. In fact, we see tracer in the airways before it even reaches the stomach. This is a patient with severe and rapid tracheobronchial aspiration of saliva. Now, here's another case. This is a 14-year-old boy with developmental delay and recurrent pneumonia. Again, tracer was administered by mouth. During the early part of the study, we see appropriate esophageal transit to the stomach, but by 20 minutes, there's accumulation of tracer in the trachea and bronchi. However, in another 20 minutes, we see that this has been cleared, telling us that ciliary clearance of the airways is intact, which is a good prognostic indicator in a patient with aspiration. Indications for a radionuclide salivagram include recurrent pneumonia, chronic cough, atypical wheezing, where there may be concern for aspiration, and nocturnal choking episodes. Occasionally, we'll see a false positive. These can include tracheoesophageal fistula or an esophageal diverticulum. Here, for example, is a 3-year-old boy with feeding intolerance and recurrent pneumonia. We can see that at the time of imaging, there's a large quantity of tracer already in the stomach. And then over time, we see increased tracer in the chest. And if you look closely, this is in fact tracer accumulation in the trachea and bronchi, telling us that that saliva has entered the airway. However, this patient was found not to have aspiration, but in fact had a previously undiagnosed tracheoesophageal fistula. When compared to a modified barium swallow performed by fluoroscopy, a radionuclide salivagram is a non-challenge test, right? It looks for aspiration of saliva, not for handling of administered food, and therefore requires minimal patient cooperation, only passive imaging after the drop of saline is placed in the mouth. Because of the sensitivity for small quantities of radioactivity, a radionuclide salivagram is more sensitive than a barium swallow for aspiration. It provides a lower radiation dose. However, the salivagram does not visualize the swallowing mechanism, and so it may still be important to perform a modified barium swallow once we have diagnosed aspiration. The third study I would like to talk about is assessment of esophageal motility. This is used for clinical assessment of dysphagia and is part of a complementary group of studies that include the fluoroscopic esophagram, which is good for finding anatomic lesions with dual contrast, may be good for evaluating mucosa, but is non-quantitative. The gastroenterologist will perform manometry, which allows them to assess segmental physiology, but this is quite invasive. And then esophageal transit scintigraphy is non-invasive and semi-quantitative and can use a variety of radiopharmaceuticals depending upon local standards. The radionuclide esophageal transit study can be performed with either liquids or soft solids, so things like water, juice, or milk, and solids can include scrambled eggs, pudding, or yogurt. We typically find out what's causing symptoms for the patient and try to replicate. The one caveat is that this is not a good test if there's dysphagia with dry solids. We image upright during a single or a series of single swallows with dynamic acquisition for 1 to 2 minutes, remembering that a normal swallow should be completed within 15 seconds. Region of interest analysis allows us to assess retention of the swallow in either the upper, mid, or lower esophagus. And sometimes we may actually need markers or do a transmission scan in some patients, depending upon their anatomy. And occasionally, delayed images may be useful. Here's an example of an 18-year-old female who was complaining of dysphagia. We provided a single swallow of liquid, and you can see rapid transit of that bolus swallow through the esophagus to the stomach. And here on the left side is a composite image of the mouth, pharynx, esophagus, and stomach, demonstrating the regions of interest of the upper, middle, lower, and esophagus and stomach. We also provide time activity curves, and this again demonstrated that there was rapid transit from the upper, middle, and lower esophagus with accumulation of tracer in the stomach, demonstrating normal esophageal transit in this patient. The indications for a radionuclide esophageal motility study include assessing symptoms if there's a negative esophagram telling us there's no anatomic lesion. It's sometimes used for functional follow-up of a known abnormality such as achalasia and provides a low radiation dose. We use a natural food, either liquid or semi-solid, and the study is semi-quantitative. Here's a 10-year-old girl with prior repair of long gap esophageal atresia. She underwent a recent Nissen fundoplication for severe reflux and now is complaining of dysphagia. The question was, is this dysphagia related to her recent surgery, or is it related to her remote esophageal atresia repair? We performed a liquid study, and even with liquids, the bolus of swallow was retained in the mid-esophagus and took many minutes to clear from the mid-esophagus to the stomach. Here we can see on the time activity curves again that it was rapid transit through the upper esophagus, prolonged retention in the mid-esophagus, and then slow passage through the lower esophagus into the stomach, telling us that she had mid-esophageal dysmotility in keeping with a late effect of her esophageal atresia surgery and not a primary problem related to her recent fundoplication. Here's a 12-year-old boy with graft versus host disease and dysphagia. He underwent upper endoscopy, which showed mucosal inflammation. And the clinical question was whether these symptoms were due just to mucosal inflammation or was there GVHD-related dysmotility. So we performed a liquid study, which was normal. And then using pudding, which was radio-labeled, we performed a soft solid study, which demonstrated retention of the meal in the lower esophagus, as can be seen both on the images and the time activity curves. So therefore, this was a patient who we could report had altered esophageal motility, which was likely due to sclerodermatous GVHD. So nuclear medicine studies in children can evaluate GI function and dysfunction using a gastric emptying study with either a solid or a liquid meal, a radionuclide salivagram, and an esophageal transit study with either liquids or soft solids. And let's talk a little bit about evaluation of GI bleeding with a study that's usually performed only in children, and that is the Meckel scan. Here's an example of a Meckel scan where we can see in the left lower quadrant a focus of radiotracer accumulation that increases over time. It does not move. And importantly, the pattern of uptake at this focus is similar to the uptake in the normal gastric mucosa of the stomach, telling us this likely represents gastric ectopic mucosa or a positive Meckel scan. The Meckel scan assesses for heterotopic gastric mucosa, which can be a common cause of GI blood loss in children. Remember that most Meckel's diverticula do not contain heterotopic gastric mucosa. In fact, sites of ectopic gastric mucosa can include intestinal duplication cysts, as well as what one might call a true positive of heterotopic mucosa in the Meckel's diverticula. This study is important because if we can tell the referring clinicians that there is ectopic mucosa and a likely heterotopic gastric mucosa in a Meckel's diverticulum, these patients can be managed with minimally invasive surgery rather than undergoing more extensive surgery to look for the source of GI blood loss. Therefore, a pertechnetate scan, that is a Meckel scan, may be the first study of choice for painless GI blood loss in children. Here's a 13-year-old boy with anemia and GI blood loss who was referred for a Meckel scan. Again, we can see over time that there is accumulation of tracer in the gastric mucosa. And also in the lower abdomen, there are multiple foci of tracer accumulation. And unlike the first study, in fact, over time, these foci move. In fact, this looks like a GI bleeding study. And this was a patient who had active gastrointestinal bleeding demonstrated during the Meckel scan. This is an uncommon finding, but important to recognize as it's important for the clinicians to know that there's active GI blood loss at the time of the study. So when evaluating a Meckel scan, it's important to recognize normal uptake patterns. The uptake timing in the Meckel's abnormality should follow that of the stomach. Remember that vascular structures, including vascular tumors, can have early accumulation of tracer, and this is going to be prior to substantial uptake in the stomach. And recognize urinary excretion of tracer. False positives are rare and are usually recognized by uptake pattern. As we saw, active bleeding can be seen. Another would be inflammation, such as that related to inflammatory bowel disease, which typically has diffuse or segmental uptake in bowel. Now, there may be many false negatives. In fact, we may miss up to a third of sites of ectopic mucosa because they may be small, less than a centimeter. They may be near the urinary tract and dismissed, or depending upon the degree of symptoms, the focus may have become necrotic or hemorrhagic in the mucosa. So in summary, we've looked at gastrointestinal and aerodigestive evaluation in children using nuclear medicine studies. We can assess GI function and dysfunction, particularly with a gastric emptying study using either a solid or a liquid meal. And this also allows us to assess for gastroesophageal reflux. We discussed using a radionuclide salivagram and esophageal transit study. And finally, talked about assessing GI blood loss in children using a Meckel scan. So I thank you for your attention.